Welcome to the Deep Dive, the place where we transform complex research and expert notes into clear, actionable knowledge. Today, we are diving into the science of sleep and why that universal feeling of persistent fatigue is maybe more than just a nuisance. It's often a signal that some pretty complex biological systems might be, well, breaking down a bit.
Absolutely.
Yeah.
If you've ever had one of those weeks where you constantly felt like it was, say, 10 p.m. when it was really only 7 p.m., especially, as the days got shorter, you really feel that your internal clock is running the show. And our sources, they jump right into this universal issue. The data often shows that, well, many of us are rarely clocking enough REM sleep.
Right.
And that single deficiency can be the root cause of that constant tiredness, that irritability.
Exactly. And we got a fantastic, really detailed stack of material this time. It covers pretty much everything. The minute-by-minute architecture of a sleep cycle, the almost dizzying range of sleep disorders that mess it up, and then maybe most crucially, the powerful central nervous system pharmacology. We're talking the heavy hitter stimulants and the complex depressants used to treat both sleep and wakefulness issues.
Okay, yeah, let's unpack this. Our mission today is basically to take you on a high-speed but well-informed tour. How did your brain manage this whole restorative process? And what are the consequences when that process fails? We're planning to go pretty deep on the critical details, especially the pharmacological side, particularly dangerous drug interactions and contraindications, things you really need to know.
Yeah, the goal is to give you the insight needed to truly understand, the importance of deep, structured sleep. And maybe what you might be risking when you try to, well, manipulate that system pharmacologically. Okay, so let's start at the very beginning. What exactly is sleep? Your sources define it quite elegantly, actually. It's a state of diminished consciousness, but where you can still be roused by sensory stimuli.
Right, like your neighbor deciding to, I don't know, run the blender at 3 a.m. You'll probably wake up. But the function of sleep, that's what makes it absolutely irreplaceable.
It's like the body's ultimate maintenance program, isn't it?
That's a great way to put it. We are talking about restoring energy, tissue repair and healing, and critically fine-tuning and improving brain function, especially memory consolidation. That's huge. Physiologically, sleep means a massive reduction in sympathetic nervous system activity.
So everything kind of chills out.
Exactly. Your heart rate, your breathing, even stuff like GI digestion, it all slows right down. Everything goes into this deep conservation mode.
And most of this restoration, it happens in non-REM or NREM sleep, which is like, what, 80% of our sleep time?
About 80%, yeah. And NREM itself is divided into these distinct phases. NREM 1, sometimes called the twilight phase, is super fleeting, maybe 1 to 7 minutes, tops. It's that really light stage where you might still vaguely hear the TV in the background. Waking up is very easy.
Okay, barely asleep then.
Pretty much.
Yeah.
Then you sink into NREM 2. This lasts longer, maybe 10 to 25 minutes, and this is where sleep deepens considerably. You need more intense stimuli to wake someone up from this stage. The sources actually highlighted a great point about waking people in this phase. They're often profoundly disoriented.
Oh, I know that feeling. That disorientation can be almost, well, dangerous sometimes. I've definitely had experiences where my kids wake me up, probably from NREM too. And I'm so confused I agree to things or have conversations I just have zero memory of later.
Huh. Yeah, the sources called that the $250 problem. The idea you might end up agreeing to buy them something crazy.
Exactly. But seriously, if you wake up feeling totally lost and groggy, you know you were probably pulled out of NREM 2 prematurely.
Right. After NREM 2, we descend into NREM 3 and 4. These are often grouped together as slow-wave sleep, or deep sleep. Now, these stages require even larger stimuli to wake someone up. And this is where most of the physical tissue repair happens. It's really essential for feeling physically recovered the next day.
Okay, so that's the body repair shop. But what about the brain? That's where REM sleep comes in, right? Rapid eye movement, only about 20% of the cycle.
Yep, about 20%. And this phase is characterized by this incredible biological paradox. It's fascinating.
A paradox? How so?
Well, your brain is highly active. It's often running these high-speed simulations, which result in vivid, sometimes bizarre and colorful dreams. In fact, if you've ever had a dream that made absolutely no logical sense whatsoever, that was probably REM sleep doing its thing. Yet, despite this, neurological frenzy, your body is completely still. It's flaccid because motor movements are profoundly suppressed.
So brain's going wild, body's locked down.
Precisely. And while the body is essentially paralyzed, your key vital signs are actually elevated. Heart rate, blood pressure, respiratory rate, they all increase. It's this state of active rest where a lot of that critical memory consolidation is taking place.
Wow. So if you're chronically lacking REM sleep, the consequences are pretty immediate.
Oh, definitely. Anxiety, irritability, a noticeable inability to focus or concentrate.
Yeah.
You feel it mentally. REM sleep is crucial for psychological healing and cognitive function.
And the structure of REM within the night matters too, doesn't it? It's not consistent.
That's a key point for the listener, yeah. In the very first sleep cycle of the night, REM is incredibly short, maybe just 1 to 5 minutes. But the REM periods get progressively longer with each subsequent cycle you complete through the night. This means you really need a long, continuous stretch of sleep, ideally more than 4 hours, to start banking those truly deep, extended REM periods that your brain craves.
So short naps or constantly broken sleep just won't cut it for getting enough REM.
Exactly. You're missing out on the longest, most beneficial REM stages that happen later in the sleep period.
And unfortunately, it seems like a lot of the things we use to maybe wind down or relax actually sabotage our REM quality.
The sources are really definitive on this. Alcohol, caffeine, tobacco, various other substances,
Mm-hmm.
they all negatively impact both the duration and the quality of your REM sleep. They basically trash it.
Okay, zooming out from the stages. This whole nightly performance, it's orchestrated by the circadian rhythm, right? Our internal clock.
Yep, our internal sleep-wake cycle,
Yeah.
fundamentally tied to the 24-hour light-dark solar day. And this entire rhythm is regulated in the brain, specifically by the hypothalamus. This becomes a critical point clinically because if a patient suffers a brain injury affecting the hypothalamus,
Right.
they can lose this balance entirely.
What happens then?
They can sometimes adopt a cycle almost like a baby sleeping all day, wide awake all night. It requires intensive environmental training using light and timing to try and reset it.
And the main conductor of this rhythm, that's melatonin, the hormone.
Melatonin, yes. The primary hormone produced by the pineal gland. Its production ramps up as it gets darker outside. That natural physiological reaction totally explains why many people feel completely drained, as early as 7 p.m. in the winter months.
It's not just mental fatigue then.
Not at all. It's your hypothalamus sensing the diminishing light and flooding your system with melatonin, signaling sleep time.
Mm.
Okay, before we dive into all the ways sleep can go wrong, let's quickly touch on how these issues are formally diagnosed. It nearly always starts with a really detailed patient history and a physical exam.
Standard procedure. But to really get to the root cause, clinicians rely on some specific diagnostic tools, right?
They do. First up is the comprehensive sleep history. This isn't just a quick chat. The practitioner gathers exhaustive detail. Your exact sleep schedule, what you perceive the problem to be, any trouble falling asleep versus staying asleep, the quality of your rest, daytime sleepiness levels, any contributing emotional or physical factors. They're essentially interviewing you about your entire sleep hygiene routine.
Okay, getting the full picture.
Exactly. That information then often feeds directly into the sleep log or diary. This is typically a 2-week record the patient keeps, and they have to be meticulous. You record your laydown time, the specific moment you think you fell asleep, total time slept, and critically, every single awakening during the night.
Every single one, with details.
Yep. For each awakening, you need to note the approximate time and, if possible, the stimulus. Was it your bladder? Was it a strange noise? A bad dream? And then you also track how you felt during the day, alert, groggy, and any naps you took.
That sounds like a lot of work, but I can see how valuable that data would be.
It's incredibly valuable.
Yeah.
Then we also bring in technology like actigraphy. This is usually a small device, kind of like a watch worn on the ankle or wrist. It measures muscle motion. And that motion, or lack thereof, serves as a pretty robust indicator of wakefulness versus sleep.
Interesting. I saw a note in the sources that a similar idea is used in surgery sometimes to gauge sedation depth.
Yeah, exactly. If the patient under anesthesia starts moving even slightly, detected by similar sensors, they're likely not sedated deeply enough. It's a related principle.
Got it. And then the gold standard, the big one, is polysomnography, the full sleep study.
That's the one. Polysomnography is the most comprehensive diagnostic tool. It simultaneously tracks 4 distinct biological metrics. You've got the EEG monitoring brainwave activity, the EKG monitoring heart activity, the EMG tracking muscle movement or lack thereof, and pulse oximetry, which measures the oxygen saturation level in your blood.
Wow, so it's looking at brain, heart, muscles, and breathing all at once.
Precisely. This multi-system approach is really the only way to accurately chart the full architecture of sleep and pinpoint exactly where a disorder might be manifesting.
All right, let's tackle the specific disorders now, starting with the ones involving that mismatch. Circadian rhythm sleep disorders, or CRSDs. These are all about a misalignment, right, between the internal biological clock and the external 24-hour day.
Exactly. The first type the sources outlined is maybe the most extreme. Non-24-hour sleep-wake rhythm disorder, N24 SWRD. As the name suggests, the person's internal clock isn't synchronized 24 hours. It might be, say, 24.5 or 25 hours long. This causes their sleep times to progressively shift later and later each day, cycling through periods of severe insomnia when they're out of sync, and then excessive sleepiness when their sleep period drifts into the daytime.
That sounds incredibly disruptive. Who gets this?
It's particularly common in individuals who are totally blind because they lack that crucial light perception cue to reset their clock daily. It can also occur in patients with specific brain lesions, often affecting the hypothalamus, that control center we talked about.
And how do you even treat something like that?
Treatment is mostly about environmental manipulation, trying to force the rhythm, using very bright light therapy during the desired daytime hours to promote alertness, and sometimes melatonin agonists at night to help induce sleep at a more conventional time.
Okay, trying to anchor the clock externally.
Right. Then we also see the irregular sleep-wake rhythm. Here, the total amount of sleep over 24 hours might be normal, but it's completely fragmented. Sleep occurs in short, scattered periods throughout the day and night, with no consistent pattern. This often correlates with severe neurodevelopmental disorders, like certain forms of autism, or neurodegenerative conditions like advanced Alzheimer's.
And what makes it worse?
Poor sleep hygiene, definitely.
Mm.
And a lack of structured daytime activity or bright light exposure can exacerbate it. A key takeaway here, though, the sources specifically cautioned that this particular rhythm disorder is frequently unresponsive to medication. It's very hard to treat pharmacologically.
Okay. Then you have the more maybe common developmental or phase disorders, like delayed sleep-wake phase disorder.
DSWPD.
Yes, DSWPD. This is characterized by extreme difficulty falling asleep at conventional times, say before 1 or 2 a.m., and therefore extreme difficulty waking up on time for school or work.
This is most prevalent among adolescents.
The classic teenager sleep schedule.
Exactly. It's driven partly by natural biological shifts in their circadian timing during puberty, but it's definitely made worse by social influences, particularly late-night use of phones and screens. That blue light exposure late at night tricks the brain into suppressing melatonin production, delaying sleep onset even further.
So the phone use is actively fighting their biology.
It really is. And this specific biological timing shift in teens is the core rationale behind the movement to start high schools later. The material confirmed this. Researchers realized forcing a teenager whose DSWPD brain might think it's still 3 a.m. to try and learn calculus at 7 a.m. is just counterproductive.
Yeah, makes sense. Shifting the start time to maybe 8:30 a.m. aligns much better with their natural rhythm.
Right. And the inverse of that is advanced sleep-wake phase disorder, ASWPD. This is the extreme early bird syndrome. These individuals have a very fast internal clock. Their rhythm runs ahead of the 24-hour day. This leads to very early sleep onset. They might feel sleepy by 6 or 7 p.m. and consequently an excessively early rising time, maybe 3 or 4 a.m., unable to get back to sleep.
Like the example in the notes, the student ready for bed at 5 p.m. and wide awake at 3 a.m.
Exactly that pattern.
Yeah.
Then we also deal with situational mismatches, which most people have experienced, like jet lag disorder.
Oh, yeah. Crossing time zones.
Right. Typically occurs when you cross 3 or more time zones. The symptoms are pretty familiar. Insomnia at night, daytime sleepiness, general malaise, sometimes even GI distress. It usually takes about 2 to 4 nights to fully recover and resynchronize.
And the advice for dealing with it?
For short trips, sometimes short-acting hypnotics are used just to get through. But for longer stays, the best strategy is to adapt to the new time zone as quickly as possible. Get on the local schedule immediately, avoid daytime naps, and definitely cut out alcohol and caffeine before your intended new bedtime, as they'll just disrupt sleep further.
Okay. And the chronic societal mismatch. Shift work disorder. This seems like a huge problem.
It's a major issue for millions working nights, rotating shifts, or very early mornings against the normal solar cycle. They experience insomnia when they try to sleep during the day and excessive sleepiness when they need to be alert and functional during their work hours at night.
Beyond just feeling tired, were there other health concerns mentioned?
Yes, and this was a significant point in the sources. There's a noted higher incidence of certain health problems, specifically breast cancer, observed in populations like nurses who work permanent night shifts over many years.
Wow. Why is that?
The thinking is that the chronic circadian disruption, the body's inability to properly regulate its hormone cycles due to constant light exposure during expected darkness, is likely a major contributing factor. It messes with fundamental biology. Management strategies really emphasize creating an environment of absolute darkness for daytime sleep, like blackout curtains, eye masks, and trying to maintain as consistent a sleep schedule as possible, even on days off, which is admittedly very difficult.
Yeah. That sounds tough. Okay, let's pivot now to maybe the most common complaint. Just plain insomnia, difficulty falling asleep or staying asleep.
Right. And the key here is the daytime consequences: fatigue, memory problems, impaired attention, and concentration. The risk factors are pretty clear from the data. Being female, advancing age, and having underlying anxiety are all associated with higher rates of insomnia.
And it's categorized by duration, right? Short-term versus
What's
chronic.
short-term insomnia lasts less than 3 months. It's usually traceable to a specific trigger, a physical or emotional stressor, a job change, a relationship issue, or even just being in an unfamiliar environment. Like that common experience you mentioned, not sleeping well the first few nights in a hotel room on a trip. That's short-term insomnia.
Okay, usually temporary. But chronic insomnia lasting over 3 months, that's different.
Much more complex, yeah. Chronic insomnia is often secondary to or tangled up with underlying medical or psychiatric conditions. We're talking things like chronic pain, which obviously makes sleep difficult, hormonal changes like during menopause, conditions like GERD, gastroesophageal reflux disease, where stomach acid comes up and causes burning, and it's much worse when you lie flat at night.
Ah, I can see how that would wake you up.
Definitely. Also, underlying heart failure or respiratory problems like asthma or COPD often worsen at night, disrupting sleep.
So treatment for chronic insomnia isn't just about sleep itself.
Not at all. You have to address the underlying cause first. But generally, treatment for insomnia always prioritizes non-pharmacological approaches first. Good sleep hygiene practices are paramount. And cognitive behavioral therapy for insomnia, or CBTI, is highly effective, especially when stress, anxiety, or unhelpful thought patterns about sleep are involved.
But medication.
Medication is really considered a last resort, or for short-term relief during a particularly bad patch. It's strictly reserved for short-term use, typically no more than 4 to 5 weeks if possible.
Okay, short-term only. But here's where we hit that really critical warning from the sources. This one seems important.
Extremely important. The sources stressed a concerning documented link between the long-term use of common over-the-counter sleep aids, specifically the antihistamine Benadryl, diphenhydramine, and an increased risk of developing Alzheimer's disease and other dementias later in life.
Wow. Benadryl, that's in so many things. Allergy meds, PM pain relievers, sleep aids.
It is, and the directive from the source material was incredibly clear and blunt. Back off on the Benadryl.
Why? What's the mechanism behind that link?
We really need to explain this why, because it's crucial. Benadryl and similar older antihistamines are highly anticholinergic. That means they work by blocking the action of a key neurotransmitter in the brain called acetylcholine, or H.
And what does acetylcholine do?
AT8 is absolutely vital for learning, memory formation, attention, and overall cognitive function. It's a cornerstone neurotransmitter for thinking clearly.
So, if you're constantly blocking AT with Benadryl, especially night after night for years,
You're fundamentally disrupting your brain's ability to consolidate memories during sleep and maintain healthy neural connections over long term. The drug might make you feel drowsy. It might knock you out, yes. But it achieves this by interfering with critical brain chemistry. It essentially corrupts the very architecture of restorative sleep and imposes a significant long-term cognitive cost.
that is sobering. Definitely something people need to be aware of if they're relying on those OTC PM meds regularly.
Absolutely. This is an insight you really need to take seriously and discuss with your doctor if it applies to you.
Okay, moving on to some other specific sleep pathologies. Let's start with narcolepsy. This isn't just being tired, it sounds much more severe.
Oh, it is. Narcolepsy is a severe neurological disorder characterized by excessive, overwhelming daytime sleepiness. And the key point is, no amount of nighttime sleep ever provides true, sustained alertness for these individuals.
What does that look like day to day?
They experience these sudden, irresistible urges to sleep during the day, often called sleep attacks. These can happen anytime, anywhere. Sleep onset can be very rapid, sometimes less than 30 minutes, even falling asleep mid-conversation or mid-activity. Sometimes it's accompanied by brief interruptions of speech, or they might perform nonsensical, automatic behaviors they don't remember later. The underlying pathophysiology points to abnormal regulation of REM sleep.
Is there a known cause?
The exact cause isn't fully understood, but there's strong evidence pointing towards a potential autoimmune link. Many patients have high levels of a specific genetic marker called human leukocyte antigen, HLA. More specifically, research points to a deficiency in hypocretins, also called orexins. These are crucial neurotransmitters produced by the hypothalamus that normally promote wakefulness. In many narcolepsy patients, the cells producing hypocretins seem to be destroyed, possibly by an autoimmune attack.
Okay, so it's a fundamental brain chemistry issue. How does that help distinguish it from something like sleep apnea? People with bad apnea are also really tired.
That's a critical distinction.
Yeah.
Narcolepsy patients are always tired, regardless of how much they slept, because their brain chemistry for wakefulness is faulty. In contrast, a patient with obstructive sleep apnea, OSA, once they receive effective treatment like a CPAP machine that keeps their airway open all night, they will feel significantly better, more alert, after a treated night of restorative sleep. Their underlying sleep architecture can be fixed. Narcolepsies can't currently.
Got it. So treatment for narcolepsy is more about managing the symptoms.
Exactly. It's focused purely on symptom management to improve alertness and control the sleep attacks. This typically involves CNS stimulants, like amphetamines, or sometimes wakefulness-promoting agents like modafinil. SSRIs can sometimes help manage related symptoms like cataplexy.
Okay. Next up, restless leg syndrome, RLS. This sounds incredibly annoying and surprisingly common.
Very common, affecting maybe 5 to 10% of the U.S. population to some degree. And yes, incredibly annoying, even maddening for those who have it severely. The diagnosis relies on that hallmark symptom, a compelling, often irresistible urge to move the legs, usually accompanied by unpleasant sensations.
What kind of sensations?
People describe them differently, sometimes creepy crawly, like bugs under the skin, sometimes aching, pulling, itching, or electric feelings. It's deeply uncomfortable.
And the key features for diagnosis.
There are a few crucial characteristics. 1. The symptoms are dramatically worse during periods of rest or inactivity, especially in the evening or when lying down trying to sleep. This makes falling asleep a misery. 2. The symptoms are partially or totally relieved by movement, walking, stretching, rubbing the legs, but the relief only lasts as long as the activity continues. 3. The symptoms are generally worse in the evening or at night than during the day.
Okay, worse at rest, better with movement, worse at night. Is it always just RLS, or can it be caused by something else?
It can be primary, meaning it's idiopathic, often runs in families, suggesting a genetic component, or it can be secondary, meaning it's caused by or associated with another underlying condition. Common culprits include iron deficiency. Checking ferritin levels is key. Also, certain neurological disorders, kidney failure, pregnancy, or even side effects from some medications like antidepressants or antipsychotics.
So treatment depends on the type.
Yes. If it's secondary, you treat the underlying cause, like supplementing iron if deficient. For primary RLS, treatment often involves medications that increase dopamine levels in the brain, like ropinirole, Requip, or pramipexole, Mirapex. Anti-seizure medications like gabapentin can also be effective. However, the sources did warn that in very severe refractory cases, sometimes benzodiazepines or even low-dose opioids might be used.
Ooh, opioids for RLS. That sounds risky.
It is, and it carries a significant danger of dependence and tolerance, especially for a chronic condition like RLS. It's definitely not a first-line approach and requires very careful consideration.
Right. Okay, now let's talk about the really prevalent one, the one that has major health consequences. Obstructive sleep apnea, OSA.
Yes, OSA is highly prevalent and medically very serious if left untreated. It's fundamentally a mechanical problem. The upper airway, usually at the level of the pharynx or throat, repeatedly obstructs or collapses during sleep. This stops airflow completely for 10 seconds or longer.
10 seconds or more. How often can this happen?
In mild cases, maybe 5–15 times an hour. In severe cases, it can happen hundreds of times a night. The sources mentioned up to 500 times in really extreme cases.
500 times a night your breathing stops. That sounds incredibly stressful for the body.
It is. The need for treatment here is critical because the consequences are severe and cumulative over the long term. Untreated OSA puts enormous strain on the cardiovascular system. It directly leads to systemic hypertension, high blood pressure, and pulmonary hypertension, high blood pressure in the lung arteries.
How does it cause high blood pressure?
Every time breathing stops, the oxygen level in the blood drops. Desaturation. The body registers this as an emergency, a stress event. This triggers a surge of stress hormones like adrenaline, which causes blood vessels to constrict and the heart to beat harder and faster, spiking blood pressure. When this happens hundreds of times a night, year after year, it leads to chronic hypertension.
Makes sense. What are the main risk factors for developing OSA?
Several key factors. Age is one. It becomes more common as we get older. Family history plays a role. Obesity is a major risk factor, as excess weight, particularly around the neck, can narrow the airway. Alcohol used before bed is another big one, because alcohol relaxes the throat muscles, making collapse more likely. And Anatomically, having a large, thick neck circumference is a strong predictor, as it physically predisposes the pharynx to collapsing inward during sleep.
And the symptoms people should look out for, or maybe their bed partners notice.
Often the bed partner is the first to notice. The symptoms are usually very telling. Chronic, loud, heavy snoring is common, though not everyone who snores has apnea. Overwhelming daytime sleepiness, despite spending enough hours in bed. And those characteristic loud, noticeable gasps or snorts as the person struggles to start breathing again after an apnea event. The sources noted these gasps can sometimes be heard clearly from outside the bedroom, even down the hallway. They sound like choking or struggling for air because that's essentially what's happening.
Scary. What are the main treatments?
Treatment strategies depend on severity, but often start with lifestyle changes. Weight loss, if overweight, avoiding alcohol near bedtime. Positional therapy can help some people, training them to sleep on their side or stomach instead of their back, as the airway is less likely to collapse in those positions. But the gold standard treatment, especially for moderate to severe OSA, is CPAP, continuous positive airway pressure.
The mask and machine.
Exactly. The machine delivers pressurized air through a mask worn over the nose or face, creating a pneumatic splint that physically holds the airway open all night, preventing collapse. There are also specialized dental appliances that reposition the jaw forward to open the airway, which can work for milder cases. Surgery is sometimes an option, but usually reserved for specific anatomical issues.
Okay, that covers the big breathing disorder. What about the parasomnias? These are the weird events that happen during sleep.
Right, parasomnias are undesirable physical events or experiences that occur during entry into sleep, within sleep, or during arousal from sleep. Nightmares are probably the most common. These are vivid, disturbing, frightening dreams that usually occur during REM sleep, often waking the person up.
Okay. Bad dreams. What else?
Then you have the NREM parasomnias, which happen during deep, slow-wave sleep, like sleepwalking, somnambulism. This involves complex automatic behaviors performed while still technically asleep. You can range from just sitting up in bed to aimless wandering around the house, opening doors, even carrying on short, nonsensical conversations.
Wow. Do people remember this?
Usually not, or only very vaguely. The sources mentioned specific, highly detailed anecdotes, people engaging in full, complex interactions like talking to family members or going downstairs for a snack, but having zero memory of it the next morning. Common triggers include stress, sleep deprivation, fever, and certain medications.
And the danger is obvious.
Extremely dangerous, yes. The biggest risk is injury, either from falling or bumping into things, or worse, unknowingly leaving the safety of the house and wandering outside.
Okay. And sleep terrors, night terrors, how are they different from nightmares?
Very different and much more dramatic and frightening for witnesses. Sleep terrors also occur during NREM deep sleep, typically in the first third of the night. It's characterized by a sudden, terrifying arousal. The person, often a child, will abruptly sit bolt upright, scream inconsolably, and show intense signs of panic and autonomic nervous system activation, sweating, rapid heart rate, dilated pupils.
But are they awake?
They appear wide awake and terrified, but they are actually confused, disoriented, and unresponsive to comfort or attempts to wake them fully. They usually have no memory of the event itself the next morning, unlike a nightmare. It can be incredibly traumatic for parents or partners to witness.
Any known triggers for sleep terrors?
Similar triggers to sleepwalking, sleep deprivation, stress, fever. Interestingly, the sources specifically link them in children sometimes to triggers like the stress of active potty training, or, more simply, the urge to urinate from a very full bladder during deep sleep.
Fascinating. We should also briefly mention bedwetting and uresis.
Yes, enuresis persisting past the typical age of bladder control. While it can have various causes, it's often related to neurodevelopmental issues. For instance, the sources noted that kids with ADHD sometimes experience such a profound crash into deep sleep when their medication wears off that their brain literally cannot process the signal from their full bladder to wake them up.
Ah, okay. And finally, in this section, let's touch on older adult sleep disturbances. This seems like a really common complaint.
It is. Over half of adults aged 65 and older report significant difficulty with sleep on a regular basis.
Why is it so much more common in older adults?
The reasons are really layered. It's multifactorial. First, there are natural age-related changes in sleep architecture itself. Older adults tend to have less deep, slow-wave sleep and less REM sleep, and more frequent awakenings during the night. Their sleep becomes lighter and more fragmented naturally. Second, increased prevalence of chronic medical conditions and chronic pain obviously interferes with sleep. Third, and this is a big one, decreased daytime activity levels. If you're less active during the day, you're simply less physically tired at night, making it harder to fall asleep.
And poor sleep habits probably play a role, too.
Absolutely. Things like taking long naps during the day can really disrupt nighttime sleep. The sources had that great anecdote about the father who takes a 4-hour nap every afternoon and then wonders why he's wide awake at 1 a.m. Older adults are also generally more sensitive to medication side effects that can disrupt sleep, like from steroids or certain blood pressure meds. And of course, physical illness, emotional stress, bereavement, anxiety about health. All these factors common in later life contribute significantly.
So it's a complex mix of biological changes, health issues, and behavioral factors.
Exactly. Addressing sleep problems in older adults requires looking at all those pieces.
Okay, let's make that major shift now into pharmacology. We'll start with the uppers, CNS stimulants. These are primarily used for treating ADHD and narcolepsy, right?
That's correct. And a core principle across this entire class of drugs is tolerance. The body adapts relatively quickly, meaning higher doses might be needed over time to achieve the same effect. And because of this, and the potential for dependence, these drugs must always be tapered off slowly under medical supervision. Abruptly stopping them can lead to severe withdrawal symptoms, like extreme fatigue, depression, and intense sleepiness.
Got it. Slow taper, always. Now for ADHD, what's the underlying issue these drugs are targeting?
The current understanding of ADHD pathophysiology involves a dysregulation, essentially a deficiency or ineffectiveness of key neurotransmitters in the brain circuits responsible for attention, impulse control, and executive function. The main players are norepinephrine, NE, dopamine, DA, and possibly serotonin to some extent.
And it's really important to stress, as the sources did, that this isn't about intelligence, right?
Absolutely vital to reiterate that. Intelligence is generally not affected in ADHD. Individuals with ADHD often appear less capable or struggle academically or professionally, not because they lack inherent smarts, but because their brain struggles with organizing tasks, maintaining focus, filtering distractions, and controlling impulses. The stimulants help normalize those functions.
Okay. The prototype stimulant mentioned is amphetamine sulfate, widely known as Adderall. How does it work?
Adderall has a powerful dual mechanism. It actively stimulates the release of both norepinephrine and dopamine from nerve terminals into the synapse. And simultaneously, it blocks their reuptake, meaning they linger in the synapse longer, enhancing their effect. The net result is dramatically increased alertness, improved mood and motivation, and significantly enhanced focus and attention.
Sounds effective, but what about the side effects? They seem significant.
They are, and they demand extreme caution and careful monitoring. Common side effects include restlessness, jitteriness, insomnia, especially if taken too late in the day, tremors, and often significant weight loss due to appetite suppression. But the most critical, potentially life-threatening side effect highlighted is the risk of cardiac issues. Specifically, increased heart rate, palpitations, elevated blood pressure, and in rare cases, serious cardiac dysrhythmias, irregular heartbeats.
Okay, cardiac risk is the big one, so monitoring is essential.
Absolutely essential. This necessitates incredibly close cardiac monitoring, especially when starting the medication or adjusting the dose. Patients must have regular blood pressure checks. Often an EKG, electrocardiogram, is recommended before starting therapy. And sometimes periodic EKGs or even an echocardiogram, ultrasound of the heart, might be needed to check heart structure and function. This is particularly crucial if the patient has any pre-existing heart conditions, even seemingly minor ones.
The sources gave a specific example here, didn't they, about heart defects?
Yes, a very important example. A patient, maybe a child or adolescent, with a known ASD, atrial septal defect, or VSD, ventricular septal defect essentially, holes between the chambers of the heart. Starting stimulant medication in such a patient requires stringent cardiac follow-up by a cardiologist.
Why is the risk so much higher with those defects?
It makes perfect sense mechanically. Stimulants dump norepinephrine and dopamine, which act systemically. They constrict blood vessels, increasing blood pressure, and directly speed up the heart rate. If you have a structural heart defect like an ASD or VSD, the heart is already working under abnormal pressure or flow conditions. Suddenly increasing the demands on that compromised heart by jacking up blood pressure and heart rate creates an unacceptable level of risk for serious complications. It could worsen shunting through the defect or overload the ventricles. So this is definitely not a class of drugs to be prescribed or taken lightly without thorough screening and monitoring.
Understood. And there's also a high potential for abuse with amphetamines.
very high, unfortunately. Because they increase alertness, euphoria, and suppress appetite, they are frequently diverted for non-medical use, either for performance enhancement, recreation, or weight loss. This is a major concern.
Okay. Now, what about the amphetamine-like drugs? The main one mentioned was methylphenidate or Ritalin. Is it much different?
Ritalin works slightly differently. It primarily inhibits the reuptake of norepinephrine and dopamine, rather than strongly stimulating their release like Adderall. So it increases the levels of these neurotransmitters in the synapse by preventing them from being cleared away as quickly. The overall effect is similar, improved focus and attention, and the side effect profile is also quite similar. Sleeplessness, appetite loss, potential for jitteriness, and importantly, still carries cardiovascular risks that need monitoring, though perhaps slightly less intense than amphetamine itself for some people.
Does Ritalin have any unique interactions we should know about?
Yes, a few interesting ones were noted. Caffeine significantly increases Ritalin's effects, so patients should be cautious about high caffeine intake. And here's that paradox we touched on earlier. For many children and adults with ADHD, caffeine often has a calming, focusing effect, helping them chill out. Whereas in individuals without ADHD, caffeine is reliably energizing and can cause jitters. It's a strange reversal.
Interesting. Any other interactions?
Critically, Ritalin can decrease the effectiveness of some other medications. Specifically mentioned were antihypertensive drugs used to lower blood pressure. Ritalin can counteract their effect, so blood pressure needs extra monitoring. And perhaps even more importantly, Ritalin can interfere with insulin effectiveness.
Wow, okay. So diabetic patients taking Ritalin need careful attention.
Extremely careful attention. Their blood glucose control could be significantly compromised, potentially requiring adjustments to their insulin dosage or diabetes management plan. That's a really crucial interaction to be aware of.
Definitely. Okay, briefly, the sources also mentioned anorexians, like phentermine.
Right. Anorexians primarily target the hypothalamus and limbic systems in the brain to suppress appetite, mainly used for short-term weight loss management.
Ah.
They do have stimulant properties, so they are sometimes used off-label for narcolepsy, but they aren't considered first-line treatment for it.
And finally, analeptics. Caffeine is the main example.
Yes, analeptics are drugs that stimulate the central nervous system, particularly the brainstem and respiratory centers. Caffeine is the classic example. It's used medically primarily to stimulate respiration, especially in premature newborns with apnea. But of course, we all know its CNS stimulant effects, increased alertness, reduced fatigue, and given that caffeine has a half-life of about 4 hours in most adults.
Ah, that explains the advice.
Exactly. That perfectly justifies the common recommendation to avoid caffeine for at least 6, preferably more, hours before your intended bedtime, because it will still be significantly active in your system, interfering with sleep onset and quality.
Okay, let's shift gears completely now to the flip side. The CNS depressants. These are the sedative hypnotics, mainly used to induce or sustain sleep for conditions like insomnia. But before jumping into the drugs, the sources really emphasize starting with non-drug approaches.
Absolutely. Non-pharmacologic management is always the essential first step and foundation for treating insomnia. You can't just medicate away bad habits. This includes all the sleep hygiene principles we discussed earlier, maintaining specific, consistent bed and wake times, even on weekends, strictly limiting daytime naps, especially long ones or those late in the day, and adhering to that crucial 6-hour rule. Avoiding strenuous exercise, heavy meals, or stimulating substances like caffeine or nicotine within 6 hours of bedtime.
What about relaxation techniques?
Also key, things like taking a warm bath, listening to quiet music or a podcast, reading a physical book, not a bright screen, practicing deep breathing or meditation, whatever, helps signal to your body and mind that it's time to wind down. These should always be tried first and maintained, even if medication is eventually used.
Right, build the foundation first. Now, when we do transition to pharmaceuticals, the sources started with the older class. Barbiturates, how do they work?
Barbiturates work primarily by enhancing the effects of the main inhibitory neurotransmitter in the brain, GABA, gamma-aminobutyric acid. They essentially make GABA work better, leading to widespread CNS depressions, sedation, sleep, and in higher doses, anesthesia or even coma. They used to be widely prescribed for sleep and anxiety, but their use is much more restricted now due to safety concerns,
How are they classified?
mainly by their duration of action. Short-acting barbiturates, like secobarbital, kick in quickly and wear off relatively fast. They were good for helping people fall asleep, sleep onset, without causing excessive grogginess or a hangover feeling the next morning. Intermediate-acting ones, like butobarbital, last longer. They were better for helping people stay asleep through the night, sleep maintenance, but they carried a higher risk of residual daytime drowsiness and cognitive impairment.
And the safety concerns. Why are they used less now?
Two extremely serious adverse effects limit their use. First, profound respiratory depression. Barbiturates can suppress the drive to breathe, especially at higher doses or when combined with other depressants like alcohol. Overdose is often fatal due to respiratory arrest. That's the primary worry. Second, they have a narrow therapeutic index, meaning the dose that's effective isn't far from the dose that's toxic. They also carry a high risk of tolerance, dependence, and severe withdrawal. And interestingly, they are also linked to increased risk of suicidal ideation. So their use today is very limited, mostly replaced by newer agents.
Okay, so barbiturates are largely historical. What about the next big class, the ones that are still widely used? Benzodiazepines, like Xanax, Ativan, Valium, and Restoril for sleep.
Right. Benzodiazepines, often called benzos, are ubiquitous. They are widely prescribed for anxiety disorders, panic attacks, seizures, muscle relaxation, alcohol withdrawal, and yes, insomnia. The main one specifically marketed for sleep is temazepam, brand name Restoril.
How do they work? Is it similar to barbiturates?
Similar in that they also enhance the action of GABA, but they do it through a different mechanism at the GABA receptor complex. They increase the frequency of chloride channel opening when GABA binds, whereas barbiturates increase the duration of opening. The end result is still increased inhibition and CNS depression, but benzos generally have a wider safety margin than barbiturates regarding respiratory depression when used alone, though still very dangerous when combined with alcohol or opioids.
Okay, safer than barbiturates, but what are the downsides? The adverse effects seem pretty extensive in the notes.
They are, and they demand meticulous attention and caution. First, common side effects include drowsiness, dizziness, lethargy, and impaired coordination, the typical CNS depression effects. Second, tolerance develops relatively quickly, especially to the sedative effects, meaning people may need higher doses over time. Third, physical dependence is a major issue. Long-term use leads to adaptation, and abrupt withdrawal can cause severe symptoms, anxiety, insomnia rebound, tremors, sweating, and in some cases, seizures. Benzo withdrawal can be dangerous and requires a very slow taper.
What about effects on sleep architecture itself?
This is important. While they help induce sleep, benzos tend to suppress deep, slow wave sleep, NREM stage 3 and 4, and REM sleep. This means the sleep quality might not be truly restorative. Some people also report experiencing vivid dreams or even nightmares, possibly related to REM rebound when the drug wears off or during withdrawal.
And the cognitive effects. That seemed like a big concern, too.
A huge concern. One of the most well-known and problematic side effects is anterograde amnesia. This means the drug impairs the ability to form new memories while it's active in the system. People might take a dose, do things, have conversations, and have little or no recollection of it the next day. This is what leads to those notorious, often alarming reports of sleep driving, sleep eating, making phone calls, or engaging in other complex, weird things while technically asleep or in a dissociated state with complete amnesia afterwards.
Wow, that's genuinely scary.
It is. And this risk leads us to the most critical warning regarding benzodiazepines, which the source has highlighted repeatedly. They're used in the elderly.
Why are they particularly dangerous for older adults?
It's multifactorial. Older adults metabolize drugs more slowly due to age-related changes in liver function, and they excrete them more slowly due to declining kidney function. This means the drugs, especially long-acting benzos, linger in their system much longer and accumulate to higher levels. They're also generally much more sensitive to the CNS depressant effects. What might be a mildly sedating dose for a younger person can cause profound confusion, disorientation, delirium, memory loss, and significantly increased risk of falls and fractures in an older adult.
So the side effects are just magnified.
Dramatically magnified. This leads to those bizarre, dangerous behaviors mentioned in the anecdotes. The older patient found kneeling on their fresh total knee replacement, completely unaware of the pain or risk. Or the patient found walking naked down the hospital hallway, utterly confused and unable to respond logically. Their physiology simply doesn't handle the drug clearance effectively. A benzodiazepine, intended as a sedative, can essentially turn into a temporary psychotic or delirium-inducing agent in the elderly.
So the takeaway is, avoid benzos in older adults whenever possible.
That's the strong recommendation. Use the lowest possible dose for the shortest possible duration, if absolutely necessary, and monitor extremely closely for cognitive side effects and falls. But generally, they should be avoided in this population due to the high risk-benefit ratio.
Okay. This high risk, especially in the elderly, is likely why the newer non-benzodiazepine hypnotics were developed. The Z drugs.
Exactly. This class includes drugs like zolpidem, Ambien, Zaloplan Sonata, and azopiclone Lunesta.
Mm.
They are chemically different from benzodiazepines, but they work similarly by selectively binding to a specific subtype of the GABA receptor complex, the alpha-1 subunit, which is thought to be primarily responsible for sedation. They were initially hoped to have fewer side effects, particularly less disruption of sleep architecture and lower dependence potential.
And do they? Are they safer?
They're generally considered safer than barbiturates and perhaps have slightly less impact on sleep stages than traditional benzos, especially Ambien, which is very short-acting. However, the hopes for significantly lower side effect profiles haven't fully panned out. They still carry risks of tolerance, dependence, and withdrawal, although maybe less severe than benzos for some people. And importantly, they are still strongly associated with those complex sleep-related behaviors like sleep driving and sleepwalking, particularly Ambien. The FDA has issued strong warnings about this.
So still need caution. How do Ambien and Lunesta differ in use?
Zolpidem, Ambien, has a very short half-life, making it excellent for helping people fall asleep quickly, sleep-onset insomnia, but it might not keep them asleep all night. Because of dependence and side effect risks, it should ideally be used only for short-term management, not nightly long-term. Azopiclone, Lunesta, has a longer half-life. It's better for maintaining sleep throughout the night, sleep maintenance insomnia.
Yeah.
It's also the only one in this class specifically FDA approved for longer-term use, although continuous nightly use is still debated and should be minimized.
Okay. And finally, there's a completely different class mentioned, melatonin agonists, like Rameltian, Rosarim.
Yes, Rameltian represents a different approach. Instead of causing general CNS depression by acting on GABA, it selectively targets the brain's own melatonin receptors, MT1 and MT2. By stimulating these receptors, it essentially mimics the natural signal of darkness provided by melatonin, helping to regulate the circadian rhythm and promote sleep onset.
So it's working with the body's natural sleep clock, not just sedating the brain.
Exactly, that's the key difference. And because it works differently, it has a different side effect profile. It generally doesn't cause the same level of next-day drowsiness, cognitive impairment, or risk of dependence and withdrawal associated with GABAergic drugs. Notably, Rameltian was the first FDA-approved hypnotic medication that is not classified as a controlled substance by the DEA.
Ah, that's significant. Suggests a much lower potential for abuse.
Precisely. It signals that regulatory agencies view its potential for abuse and dependence as substantially lower than benzodiazepines or Z drugs. It's often considered a good option, especially for sleep-onset insomnia or in patients where dependence is a major concern, like those with a history of substance abuse, or sometimes in the elderly.
Okay, to wrap up our pharmacological tour, we need to briefly bridge into the surgical and procedural setting, looking at drugs that push CNS depression to its absolute limit. Anesthetics and neuromuscular junction, NMJ blockers.
Right, these are used for surgery or procedures requiring deep sedation or paralysis. Many 5E anesthetics seem related to the drugs we just discussed. They are. Many general anesthetics, both inhaled and intravenous, work at least in part by enhancing GABAergic inhibition, similar to benzos and barbiturates, but achieving a much deeper level of CNS depression, unconsciousness, and lack of response to painful stimuli. 4 anesthetics, like midazolam versed, which is a short-acting benzodiazepine, are often used for induction of anesthesia, or for conscious sedation, creating that twilight phase, where the patient is deeply sedated and amnesic, but still somewhat responsive to verbal commands or tactile stimuli, like during a colonoscopy.
Got it. But the source material spent specific time on propofol, Diprivan. What's important about propofol?
Propofol is a very widely used 4V anesthetic agent. It's known for its characteristic appearance. It's a white, milky emulsion. It acts incredibly fast, inducing unconsciousness usually within 60 seconds of injection, and it has a very short duration of action, typically lasting only about 3 to 5 minutes after the infusion stops. This allows for rapid recovery and fine control over the depth of anesthesia.
Okay, fast on, fast off. But there was a critical safety warning mentioned, often highlighted for exams and practice, something about infection.
Yes, this is absolutely critical to know about propofol. Because it's formulated in a lipid emulsion, that white and milky substance, it provides an excellent medium for microbial growth. Bacteria are strongly attracted to it and can proliferate rapidly within the vial or infusion line if strict aseptic technique isn't followed.
Wow, so it can actually grow bacteria.
It can. Therefore, propofol is either completely contraindicated or must be used with extreme caution in patients who already have an active infection or sepsis. Using it could potentially worsen the infection by providing a growth medium for the bacteria circulating in their bloodstream. Furthermore, because of this risk, Strict handling protocols are essential. Vials must be drawn up immediately before use using sterile technique, and any unused portion must be discarded promptly, typically within 6 or 12 hours, depending on guidelines. You absolutely cannot save partial vials for later use due to the risk of contamination. This is a fundamental point of patient safety.
Understood. High infection risk. Careful handling needed. Caution in septic patients. Now, what about the drugs used for paralysis during surgery? The neuromuscular junction, NMJ, blocking agents.
Right, these drugs, often called paralytics, don't affect consciousness or pain sensation at all. They work peripherally at the neuromuscular junction, the synapse where motor nerves communicate with muscles to induce muscle paralysis. This is necessary for many surgeries to prevent patient movement, relax muscles for easier surgical access, and facilitate mechanical ventilation by paralyzing the respiratory muscles. They work by manipulating the action of the neurotransmitter acetylcholine, ACA, at the muscle's receptor site.
Okay, they target AOC at the muscle. Was there a major contraindication mentioned based on that?
Yes, a critical one. Because they directly interfere with AUC's transmission at the neuromuscular junction, NMJ blocking agents are absolutely contraindicated in patients with myasthenia gravis.
MG, remind us what myasthenia gravis is.
MG is an autoimmune neuromuscular disease where the patient's own immune system attacks and destroys their acetylcholine receptors on the muscle cells. This leads to fluctuating but often severe muscle weakness that worsens with activity. Giving an NMJ blocker to someone who already has a deficiency of functional acetyl receptors could result in profound, prolonged paralysis, making it extremely difficult or impossible for them to regain spontaneous breathing function after the drug is supposed to wear off. It's a potentially fatal combination.
Okay, absolute contraindication in MG. How are these blockers classified? There were two types.
Yes, they're divided into two main classes based on their mechanism of action at the ACO receptor. First are the non-depolarizing blockers, like rocuronium or vecuronium. These drugs act as competitive antagonists to acetylcholine. They physically bind to the ACO receptors on the muscle cell but don't activate them. They simply block AC from binding and stimulating the muscle. This prevents muscle depolarization and contraction, resulting in flaccid muscle relaxation or paralysis.
And are these safe if the patient has, say, a broken bone?
Yes, non-depolarizing blockers are generally considered safe to use in patients with fractures because they simply cause relaxation without any initial muscle stimulation or movement.
Okay. What's the second type then?
The second type is the depolarizing blocker. And interestingly, there is currently only one drug clinically used in this entire class, succinylcholine. Succinylcholine works very differently. It acts as an agonist at the ACA receptor, meaning it actually mimics acetylcholine. It binds to the receptor and triggers depolarization of the muscle cell, causing an initial muscle contraction or twitching, often visible as muscle fasciculations. However, unlike ACH, which is rapidly broken down, succinylcholine persists at the junction, keeping the muscle cell depolarized and unable to repolarize for subsequent contractions. This results in a state of paralysis known as depolarizing blockade. The muscle is essentially locked in a temporarily unexcitable state after the initial firing.
So it causes a big contraction first, then paralysis. That seems important.
Extremely important, especially regarding fractures. Because of that initial intense muscle stimulation and contraction, fasciculation, you should never use succinylcholine in patients with major trauma or known fractures. That initial violent muscle spasm is strong enough that it could potentially cause movement or displacement of unstable fracture fragments, risking further soft tissue injury, nerve damage, or converting a closed fracture into an open one.
Wow. Okay, so non-depolarizers like rocuronium relax muscles, safe with fractures. Depolarizer succinylcholine contracts, then paralyzes, never used with fractures. Got it.
That's the critical distinction for safety. So we have covered a huge amount of ground today, a really extensive deep dive into the whole world of sleep. We detailed the absolute necessity of getting enough structured NREM sleep for physical restoration and that crucial REM sleep for cognitive function, memory consolidation, and emotional regulation. And we looked at how this is all orchestrated by that delicate hypothalamic-controlled circadian rhythm timed by light and melatonin.
Yeah, and then we walk through how problems are diagnosed from that detailed sleep log and maybe actigraphy, all the way up to the comprehensive multimetric polysomnography, the full sleep study. And then we spent a lot of time on the pharmacology, the powerful, often high-risk drugs used to manage these conditions, the CNS stimulants like Adderall and Ritalin, demanding like careful cardiac monitoring due to blood pressure and rhythm risks, and those tricky interactions, especially with insulin.
Right. And the CNS depressants, the older barbiturates with their respiratory risks, and the widely used benzodiazepines. We really hammered home the dangers there, especially the anterograde amnesia leading to complex sleep behaviors and the critical warning about avoiding them in older adults due to their heightened sensitivity, slower metabolism, and risk of profound confusion and falls. Even the newer Z drugs like Ambien and Lunesta still carry risks, although melatonin agonists like Rosarum offer a different, potentially safer approach by working with the circadian system.
And we finished with those critical safety points in the procedural setting, remembering propofol's unique infection risk and the need for careful handling, and those absolute contraindications for NMJ blockers, avoiding any of them in myasthenia gravis, and specifically avoiding succinylcholine if there's a fracture.
Exactly. We covered a lot of the key details from the sources.
And as we wrap up, maybe a final provocative thought for our listeners to mull over, building on what we discussed. We spent some time on that really concerning link between common anticholinergic over-the-counter sleep aids, especially Benadryl, and the long-term risk of neurocognitive disorders like Alzheimer's and dementias.
Yeah, that anticholinergic burden is a serious consideration. So, considering how absolutely essential we've established deep, high-quality REM sleep is for memory consolidation, for brain cleanup, for psychological healing, what deeper, maybe unrecognized long-term costs might we be incurring individually and maybe even societally by consistently relying on substances that, yes, might induce drowsiness, but do so by actively blocking key memory neurotransmitters like acetylcholine and fundamentally disrupting our natural restorative sleep architecture.
Right. It's that trade-off, isn't it, between feeling knocked out quickly tonight versus potentially compromising long-term cognitive health. It's a profound question.
It really is. That choice and understanding the mechanisms behind it is something that definitely warrants your own continued exploration and discussion with healthcare providers.
Well said. Thank you again for sharing all your sources with us and for participating in this very detailed deep dive today.
My pleasure. Always fascinating stuff. Until next time.